So let's talk about approaching the questions. First, how are questions written? We actually published on this. You're welcome to look at it. These are open access as well. We are not trying to keep this proprietary. We want everybody to benefit from it. So everybody does this. Doesn't matter if it's the MCAT or the boards, SAT, EM Coach. The appropriate way to go about writing a question follows a sequence. You come up with a single, simple fact. Then you look at the importance of that knowledge. And the importance of that knowledge comes from the model of the clinical practice of emergency medicine. If you haven't heard of this, that's okay, but we have. And it's the model by which all the different societies with emergency medicine came together and said, what does an emergency physician need to know? You may notice EM Coach has 20 chapters. Why is that? It's because that's exactly what the model of the clinical practice of emergency medicine has. Pediatrics is not a separate chapter in EM Coach. Why? Because it's not in the model of the practice of emergency medicine. They're telling you what's on the exam. It literally is this 60-page document that goes through every single topic and every single subtopic that you need to understand. And you might notice a very distinct similarity between that structure and EM Coach. They're telling you what's on the exam. Why not use it? This is an open document. Use it to study, and that's what we've done. We have broken down that document for you to be able to take in piecemeal and study to be ready for the test. So that's how they figure the importance of that knowledge. It has to be part of that model of the clinical practice of emergency medicine, that single fact. So, single fact, is it within our scope? And then look at the depth of understanding. Is it just a remember thing, like how many of this are necessary or how many are that, or is it an application thing, which is the next best step? Those kind of ideas, there you can test the depth of understanding, and that's using Bloom's taxonomy, which is beyond the scope we're talking about now, but that's very much part of how they decide how difficult of a question they're going to make it. Then they come up with a question structure. Is it going to just come out and ask you that information, or will it be in a case scenario like a STEM and vignette? And then you look at the FOIL structure. So the FOIL structure is going to have similar wording, similar difficulty, similar length to try to make them as similar, all these options as possible. And that helps the question perform better. So this is the approach that they take. You have to understand as you're going through a question, if it's coming across weird, you're not understanding it, take a step back and pretend that you're a question writer. What nugget of information would be important? Maybe a deep kind of analysis question or apply question could you be trying to write? What are they trying to test out of you? So what information is tested? It has to be a demonstrable fact. And this is one of the things that comes up pretty often. People will say, well, we do it this way, or this is available at our hospital or not. That's not going to be tested. It has to be something that's a demonstrable fact. So these would be society and international group guidelines, college and academy clinical policies, or maybe antimicrobial guidelines. This is where this stuff comes from. They have to be able to tell you, no, all those other choices are demonstrably wrong. So what do you do with all this that I'm telling you? You're not going to be necessarily writing questions. How does that help you? Well, let's apply it. First, we're talking about identifying the knowledge nugget. So take a look here. Give you a second to read it. So essentially this is a gentleman who comes in with an attempted hanging, and on exam there's a small little spot on the neck, and it wants to know, what do you want to do, right? The whole point of that vignette is the imaging after hanging attempt, right? So the patient's alert and that the workup should be driven by the physical exam findings. That's the nugget out of that whole thing they're getting at, right? What do you do with this particular situation? So let's go to the next point here. Avoid the protocol mentality. So this is a patient who comes in with a stroke, and they give you a blood pressure and some exam, and then they show you the CT scan, and they say, what do you want to do next? Now you can look at that and say, oh, we got to do Alteplase. Or you could say, oh, no, our center, we would move right next into the CTA or the CT perfusion. And the key here, if you're looking through, what are they getting at? They're getting at the blood pressure, right? So if you're talking about perfusion, where is that going? The CT perfusion is going to be leading you towards some sort of endovascular approach, right? But you can do that within a matter of hours. It doesn't have the same strict timeline and that big jump at after 3 hours, right, that TPA has in terms of adverse outcomes. What they're getting at, what they're testing, and this makes a lot of sense if you think about it, is the blood pressure. The most important thing they're going to test from you is not your protocol of what comes after a CT scan non-con, you're going to do perfusion. That's a kind of obvious answer. What they're going for is the blood pressure. It's too high. You can't push TPA. So they want you to lower the blood pressure. So it's figuring out what are they getting at in the question. It's not that it's a trick question. You really can't demonstrably say that getting the CT perfusion versus going ahead with something else is demonstrably wrong. So that's not the answer. The answer is what they can demonstrate to be correct or incorrect. What you see is what you get. So in this one, this is a patient who has neurocystic sarcosis. And the question is getting at, and then has a seizure, right, with this neurocystic sarcosis. The question is getting at what's the best therapy. Now, if you read this question, you're thinking, no, benzodiazepine's not an option, or I need levetiracetam because she's seizing. That's not an option. If it's not an option, then you're going down a different rabbit hole than they want you to. I mean, it's not to say that clinically that would be wrong. In fact, yes, benzodiazepines would be absolutely indicated for this patient if she's continuing to seize. But they have to limit. They can't test everything about a seizing patient with neurocystic sarcosis, right? They have to limit down to that one nugget point. If you see a smattering of things they could ask you in a question, take a step back, maybe take a deep breath too, and ask yourself, what one thing are they asking me in this question? The caveat to that is sometimes you have secondary questions where it's two things. It's diagnosis and then a treatment, or diagnosis and complications, whatever, right? But they're focusing on that one nugget of information nonetheless. And in this case, they're not asking about treating the seizure. They're asking about how do you treat the actual parasite with mebendazole. So one other tip that I want to point out in the questions, and this is great because it can save you a lot of time, is look at the similarity amongst the incorrect questions. So this is asking you the 3 points to look for a DVT, for 3-point compression, right? But if you look at that, and so you're thinking, man, I do 2 point at my shop. Those aren't DVTs, or sorry, those aren't deep veins. The tibial veins, great saphenous vein, those aren't deep veins. Well, those can't be part of the exam. There's great saphenous vein again. There's a lesser saphenous vein. That ain't a deep vein. And look at that. We've wound up with only one option that actually has all deep veins. Done. You don't actually have to know all 3 points for that DVT exam. You just have to be able to recognize which veins are deep. Done. Point to you. And this is one of those things that's different about clinical medicine versus the test medicine, which I get it. It sucks. It does. But this is the reality. And so if this is the hand that we're dealt, we can at least make the most of that hand.